good evening, everyone, and I'd like to welcome you to the Sleep Disorder, Breathing and Severe Asthma, organized by the Emirates Thoracic Society. It would be a very interested webinar where we're combining both sleep disorders and severe asthma. The first two talks will be on sleep disorders. I'll be talking about obesity hypoventilation syndrome, followed by Dr. Arizwana, who will talk about NIV for neuromuscular disease in pediatrics. And then the second two talks would be about severe asthma, both the characteristics and predictive biomarkers. So I hope that you will enjoy it. If you have any questions, please feel free to type it on the Q&A chat. Also, this webinar is accredited with 3.5 hours, and you will receive the CME certificate once you fill in the evaluations, hopefully by maximum tomorrow. Is Dr. Ashraf around? I could see him typing something there. Dr. Ashraf, would you like to say something?
Yeah, he's joining now.
Excellent. So, well, we should wait maybe for the chairman to say hi to everyone, and then I can start. Come salam, Dr. Ashraf.
يعطيك العافية أبو سليمان.
الله يعافيك ويسلمك.
الله يوفقكم إن شاء الله. I'm glad to see the sleep disorder breathing group in action. I wish you all the best, and I'm looking forward for the speakers and the discussion followed after that together with the severe asthma group.
Sure. Well, thank you for giving us the time. And also, I'd like to thank our sponsors and thank MCO for organizing the webinars.
يعطيكم العافية. Thank you very much. Thank you for your hard work.
Right. So let me introduce myself. My name is Dr. Mohammed Al-Hawqani. I'm Associate Professor at the College of Medicine at UAE University. I'm also a consultant of respiratory at the Sleep Disorder Specialized Clinic here in Al Ain. So I'll be talking about obesity hypoventilation syndrome, and I thought that we'll make it a little bit interactive. I will start with a case. So the case is a 72-year-old gentleman who has a past medical history of hypertension and diabetes mellitus type 2, was admitted to hospital with shortness of breath on exertion and edema. And basically, he had no cough, no runny nose, no sputum, and no wheezing. His blood pressure was around 135/90, heart rate was 84, oxygen saturation was on the low side of 92% on room air, and his BMI was 45. On examination, he had crackles bilaterally and +1 pitting edema. We've done an arterial blood gas for him, and it showed a pH of 7.25 with CO2 of 83. Oxygenation was 100 and bicarb of 34. And this was on 4 liters of nasal prawn. Investigation was positive for BNP and was 1,500. Now, he was started in the CCU with a bilevel, 18/6, and with FiO2 of 25%. He was also seen by cardiologists and started on a diuresis. 3 days later, he did improve, his edema did improve, and our oxygenation did significantly improve. His pH now, he was acidotic, as you've seen it, was more of respiratory acidosis, and now his acid-base balance showed pH of 7.37 and CO2 of 62, still on the high side. Oxygenation was fine on room air, 86%, and bicarb of 30. So my question to all of you, and I hope that you can make it interactive here, is which of the following would you do before or at discharge? Referral to outpatient sleep clinic, or maybe outpatient home sleep testing, outpatient in-lab sleep study, or would you send him home with empiric bilevel? Okay, so what would you do? Okay, so we'll give it another 5 seconds. Great, so I see 32% voted. Now, interestingly here, maybe I'll end the polls and so we can all see the result. So the majority would like to do an outpatient in-lab sleep study or referral to outpatient sleep clinic, which is almost the same. only 10% are thinking of sending him home with empiric bi-level. This is really interesting, and I think this is why we need to review the new guidelines from American Thoracic Society, because it seems that if we send him, as you just suggested, if we refer him to a sleep study, which may take a month or two, depending on where you're going to send him, waiting, that will increase the patient mortality. So let's review. So what I'm talking about here is the American Thoracic Guidelines, which was published last year, addressing the evaluation and management of obesity hyperventilation. And before we start, we need to agree on the definition. So basically, we're talking about obese patients with BMI of more than 30 who have a weight carbon dioxide of more than 45 after excluding other causes of chronic alveolar hyperventilation. Now, most of them have also concurrent obstructive sleep apnea, and the majority, more than 70%, have severe obstructive sleep apnea. And they are frequently treated with either a CPAP or BiPAP. And yes, we do need a sleep study to look for concurrent obstructive sleep apnea. Now, talking about the obesity hyperventilation syndrome and the pathophysiology, so it's more related to the abnormal chest and lung mechanics with more central fat, leading to reduction in the FRC, reduction in the compliance, and as a result, reducing the tidal volume and minute ventilation. And actually, most of my obesity hyperventilation patients who are BMI of more than 45, they always tell me, doctor, we'd rather to sleep sitting up on a chair. We cannot lay down. And I know, and I understand why. And it's all about the central fat pushing the diaphragm, and they cannot really ventilate very well. It's also related to changes in the upper airway patency, which lead again to sleep apnea and increased hypoxemia, and also related to altered respiratory control. And so with a chronic respiratory acidosis, they have reduction in hypercapnic ventilatory response and reduction in hypoxic ventilatory response. So the consequences of untreated obesity hyperventilation syndrome are they are at higher risk of pulmonary hypertension, worsened exercise capacity, and increased healthcare utilization with increased ICU use, vent use, length of stay, and increase in mortality. Now, the American Thoracic Guideline addresses 5 issues here. The first one is the use of arterial carbon dioxide to diagnose obesity hyperventilation, serum bicarb, and oxygen saturation. It also addressed the use of positive airway pressure versus no positive airway pressure, PAP versus NIV, and management of obesity hyperventilation at hospital discharge, weight loss recommendation. So let's start with the first one. Now, if you have a patient with strong suspicion of OHS, I'm talking about a BMI maybe of more than 40, someone who's short of breath, nocturia, edema, and maybe mild hypoxemia during a week, it's a must to do arterial to check the carbon dioxide to rule in the diagnosis of OHS. Now, if you have someone with a low to moderate chance of having OHS, I'm talking about someone with a BMI of 35, you're not sure, he's not really symptomatic, you could do a serum bicarb. And if a serum bicarb is less than 27, you could actually rule out obesity hyperventilation syndrome. If it is more than 27, it's recommended to go and confirm the diagnosis by ABG and check for the carbon dioxide. Oxygen saturation should not be used to determine when to measure the carbon dioxide. I know a long time ago we used just to look at the oxygen saturation. If it is low, we said, oh, next step, we do ABG. But, well, if you got the symptoms, and despite a good oxygen saturation, you need to do the ABG. The second recommendation is use of PAP versus no treatment. And this was based on pooled data and many articles that showed that using PAP, like such as a CPAP or an IV, would reduce the AHI by more than 50 and reduce time spent with oxygen saturation less than 90. And this is what we do during sleep study. Like we look at how much time the patient spent less than 90. And most patients who have obesity hyperventilation, they have majority of the time of at least 10% of the sleep study less than 90. So yes, the positive airway pressure would reduce the AHI, improve oxygenation, improve awakening, arterial oxygen, and reduction of arterial carbon dioxide. It does improve the quality of life, the sleepiness, and a better sleep continuity with reduction of arousal index. Now, the third recommendation was CPAP, not BiPAP or an IV, should be used for stable ambulatory patient with obesity hypoventilation. And long time ago, and many physicians are thinking that, oh, he has a hypercapnia, and hence we should give him a BiPAP. But during titration, many patients, we found that CPAP sometimes in someone who's stable enough and after treated with an IV in hospital, it can be sufficient to both abolish the obstructive sleep apnea and obesity hypoventilation. The fourth recommendation is discharge hospitalized patients suspected of obesity hypoventilation with an IV. And again, based on data that showed patients who were discharged without an IV had a higher mortality of up to 17% if discharged waiting for sleep study. And good luck, in some places we're talking about few months. So very important to start them with American IV before discharge. Okay. Now, outpatient sleep study is still recommended, but can be done within 3 months if the patient is having an IV. The fifth recommendation was about weight loss, and we're talking about 25 to 30% of the actual body weight. And again, based on 2 randomized controlled trials and 7 cases series, which showed that reduction of 27 to 30% of body weight resulted in reduction in carbon dioxide by 10 millimeter and improvement of pulmonary artery pressure. So the summary of the guideline is, number 1, we need arterial blood gases to look for carbon dioxide. Testing recommended for high risk of obesity hypoventilation. Number 2 is serum bicarb less than 27 recommended as a screening for outpatient with mild to moderate risk. And this is very good for someone like us who have an outpatient sleep lab. Sometimes ABG is really hard to do as an outpatient. Serum bicarb, a simple one for someone with a mild to moderate risk, can help you to screen for obesity hypoventilation. The third recommendation is positive airway pressure for sure during sleep. And the fourth one, if you do titration, start with a CPAP, especially if the patient is having severe obstructive sleep apnea with AHI of more than 30. The fifth one is recommended if you have patients in hospital with obesity hypoventilation, please start them with American IV before getting the sleep study. And then we need always, and sometimes that, unfortunately, as a respirologist, you forget to talk about weight, but I think this is really important to involve dietitian in helping and treating these patients, because weight loss of 20% not only improve the obesity hypoventilation and obstructive sleep apnea, but also the pulmonary pressure and other cardiovascular morbidity. So there's a really nice diagram that you can view it if you have a chance to look at the American Thoracic Society statement, and it's summarized of what we just talked about. To summarize it here, I would say look for ABG carbon dioxide of more than 45 for high probability. You could rule out OHS if bicarb is less than 27. Treat them with PAP, and for patients with severe obstructive sleep apnea, CPAP is over BiPAP for sure. If you discharge patient with an IV, with empiric and IV and talk about weight loss of 25 to 30%. And do not use oxygen saturation to diagnose or rule out obesity hypoventilation syndrome. Now let's go back to our case, who was admitted to hospital, was treated with BiPAP. He did well in the CCU. He's ready to be discharged. As we just said, he was on BiPAP of 18/6. His carbon dioxide went down from 83 to 62. His ABG, pH normalized. It was acidic and now 7.37. And he never had an issue with oxygenation. I should have a question here. Okay, well, question should be coming soon. So it was started, and this is a question as well, Doctor, what pressure should we start in when it comes to empiric BiPAP? I'm ready. I would say we're blessed that we have a new technology now. It's called the average volume assured pressure support, AVAPS. It's available with both Respironix and Resmed, where you could assure that the patient is getting the tidal volume. So this patient was started with intelligence VAPS with auto EPAP as well. The patient height was 184. So what we have to do is to calculate his ideal tidal volume based on his height, which was, in this case, HCC per kg was a 640 ml. His target respiratory rate, 15. Target alveolar ventilation is 7. And we did turn on the auto EPAP, but the minimum EPAP of 4, maximum of 15, and pressure support, we gave it a range of 4 to 5. Now he came for follow-up to download the data after 1 week, and we found that 90% of the time he's at pressure of 15/10, respiratory rate 23, tidal volume around 300, good mask fit with no leak. And we also calculated something, we call it the rapid shallow breathing index, and it was 78, which is really high. So the rapid shallow breathing index is basically the respiratory rate divided by the tidal volume, and it's used in ICU to help weaning out patients. Now, this is my question to all of you. Are you happy with what you see in here? The patient overall did not, I would say, we look at his BiCAP, did not improve, and clearly we're not ventilating him well because the tidal volume is 300, whereas the ideal one should be 640. So my question, okay, my question, and this is the second one, let me just move into the second question. Yes, okay. So the question is, what changes would you suggest for this AVAPS to improve his tidal volume? Would you increase the pressure support range? It was 4 to 5. Would you go to 4 to 15? Or would you increase the maximum EPAP to 20 because it was maximum of 15? Or would you just change his mask, maybe from full face to nasal? Or would you do nothing and follow up in 1 month? Okay, I'll give you 15 seconds. Let's see. Excellent. Well, I'm really happy to see that the majority actually would increase the pressure support range 4 to 15, and that's what we've done. Okay. So moving forward, so what we've done, again, we did increase the pressure support from 4 to 15, and that allowed improving not only the tidal volume and also minute ventilation. Something else that we've done is increasing the TI time, the inspiratory time. And most patients with obesity hypoventilation, they need more time to breathe in, okay, unlike the COPD patients. So following up after 1 week, the patient attained pressure of 20/12. His respiratory rate is pretty good, 12. Remember, it was more than 20. His tidal volume now is fair enough, 580. I know we're aiming for 640, but 580 is really good, and it's better than 300. there's no mask leak, and his rapid shallow breathing index went down from 70 to 40, which is fine. Anything 40 and below, I'm really happy. So a few questions for the next few minutes is why not just treat the patients with oxygen? And unfortunately, I've seen this a lot, where patients coming to hospital and before discharge, they had 2 cylinders of oxygen and maybe a portable oxygen also for his car when he goes out around. Do you think that would help the patient? Well, actually, studies showed that would increase his mortality in the first 3 months. And oxygen will drive the CO2 retention and will not abolish the obstructive sleep apnea and arousals, and will not improve, again, in the absence of positive airway pressure, will not prevent the recruitment and atelectasis, and that would result in an increase of work of breathing, the dead space, and the BQ mismatch. So no to oxygen. Actually, most of the time, my job is to get oxygen out of my patients and replace it with an IV. A sleep study was not used to establish the IBAP settings. What are the principles used to choose effective settings? So my recommendation is always set up a backup rate of 15 and do not use the learn target auto backup rate. I hate it. I know it's available on some machines. Unfortunately, it can lead to increased tachypnea in patients. Set the tidal volume always 8 to 10 cc. Set the inspiratory time of 1.2, you can go up to 1.4. If you have a function of auto EBAB, I know not all of the machines will have it, better to use it. And then give a higher pressure support. 4 centimeter is not enough to ventilate someone with a BMI of 40. Be generous, go up to 10 or 15. Okay, another question that I always get it, that what are the most important factors to evaluate for home-based monitoring of ABAPs? So when I look at the adherence, I'll look at the number of hours of use, and I always say 4 hours is minimum. The more you use it, the lower the CO2 and the lower the risk of cardiovascular morbidity and mortality. Look at the mask fitting and also look for AHI, hoping that's less than 5, tidal volume, respiratory rate, hopefully less than 16, and the rapid shallow breathing index. Excellent, I think I'm on time. I will take 1 or 2 questions before we move to the second speakers. And please feel free to type your questions in the Q&A. Okay. Wow, excellent. Well, I don't see any question. So maybe we can move to the second speaker. And let me stop sharing. So I'd like to introduce now Dr. Rizwana Popita, who's a consultant in pediatrics, pulmonology, and sleep medicine at King's College Hospital, London, UAE. She will be talking about NIV for neuromuscular disease in pediatrics. Please welcome Dr. Rizwana.
Hi, my name is Rizwana Papatia, and I'm a pediatric pulmonologist and sleep medicine specialist. Today, my topic of presentation is pearls in the management of patients. And here we are talking about pediatric patients because neuromuscular disease covers from young infants to adolescents to adults. And we're going to look like, what is new in the management of these patients with neuromuscular disease. And let's start with a vignette. So we have a 2-year-old child, and again, I'm a pediatrician, so I'm going to start with our pediatric case. So we have a 2-year-old child who presents with pneumonia and diffuse weakness. He was diagnosed with spinal muscular atrophy at 16 months of age. He also has history of 4 previous pneumonias. No difficulty while feeding. He can sit unsupported. What is the best recommendation for preventing future pneumonias? And the options are, do you want to tracheostomize the kid? You want to put a PEC tube or a G tube and fundoplication? You want to start non-invasive ventilation at night? Or you want to give chronic preventive antibiotic to this child? So let's start the poll. So we can end the poll, and 58% of people think that we should start non-invasive ventilation at night. And that is the correct course of action to start non-invasive ventilation in this child. The kid is able to breathe by his own, like, there is no oxygen requirement, there is no evidence of CO2 retention, so there is no point in putting a tracheostomy in this child. He's feeding without any issues, so there is no point for a G-tube. And recurrent pneumonias can be one of the manifestation of hypoventilation and inadequate breathing at night. So this is very important to keep in mind. Let's move on. So what are the neuromuscular diseases? So these are diverse groups of acquired or inherited conditions which involves nerves or the muscles or the neuromuscular junction, as the name suggests. Now this disorders, all this, we kind of bunch all this neuromuscular disease into one compartment, and all these diseases have common features of chest wall and lung underdevelopment. It starts very early in utero as well, and it is very progressive too. Then you have impaired cough due to respiratory muscle weakness, and this leads to impaired airway clearance. And impaired airway clearance leads to retention of secretions, and you have recurrent pneumonias or recurrent lung infections. Because of the respiratory muscle weakness, these subjects also have hypoventilation with sleep. This could be obstructive, central, or both. Again, the pharyngeal muscle weakness leads to swallowing dysfunction and dysphagia, increase in the episodes of gastroesophageal reflux and aspiration. The hypotonia because of muscle weakness leads to reduced diaphragmatic strength and weakness of upper airway dilators. And that again precipitates the obstructive events. And these patients also have cardiomyopathy, which contributes to the sleep disordered breathing. Now, let's look at the lung function. So what happens in lung function of patients with neuromuscular disease? So if you remember, your total lung capacity equals to your vital capacity plus residual volume. So vital capacity reduces well before total lung capacity in these patients with neuromuscular disease. And why does the total lung capacity does not reduce if your vital capacity reduces? Because your residual volume increases because of expiratory muscle weakness. You have a lot of air trapping, and that increases your RV or your residual volume, and that balances the total lung capacity, but your vital capacity of the patients reduces significantly. Vital capacity is further reduced in supine position because of the diaphragmatic weakness. And we'll look at the diagrammatic representation of it. And it has been shown in studies that there is 25 to 50% drop in vital capacity between sitting and supine position. So it's a very smart idea to do a sitting and supine spirometry in this patient to diagnose the drop in vital capacity early, because your total lung capacity can remain normal or near normal for a long time before it actually drops. So let's look at, this is the comparison of individual lung volumes in normal subject versus subjects with neuromuscular disease. So I'm going to point to the normal. Can you see my cursor? So this small is, are you guys seeing my cursor or no?
Yes,
Yes.
we see.
Okay. So this is your tidal volume. The small gray area is the tidal volume. The black part is the inspiratory reserve volume. This light part is the expiratory reserve volume. And your tidal volume, inspiratory reserve volume, and expiratory reserve volume in total, this is your vital capacity. And the dark gray area is your residual volume. Now, this is in a normal individual with baseline lung volume of a 45-year-old man with a weight of 68 kilos and height of 175 centimeters. So this is your vital capacity. This is your, and the gray area is your residual volume. Now, coming to a patient with neuromuscular disease, you see a reduced vital capacity, but the total lung capacity is kind of same. Like, the total lung capacity is the entire bar. So it is kind of similar, but you see reduction in vital capacity, and this comes at the cost of increase in the residual volume, which is your blue area. So there is increase in residual volume, there is decrease in vital capacity. Now, in supine patient with neuromuscular disease, you see there is a decreased functional residual capacity, which is your expiratory reserve volume and your residual volume. So this part is reduced, and there is reduced vital capacity and there is reduced total lung capacity. The whole bar has reduced. And when you see in the sleeping supine position in neuromuscular disease, this FRC or functional residual capacity is further reduced, and you see there is a decrease in the tidal volume too. So as you can see, the vital capacity decreases consistently and the total lung capacity reduces in supine sleeping position of a patient with neuromuscular disease. So it's a wise idea to do a spirometry both in sitting and supine position. Now let's look at this data of nocturnal oximetry in a patient with right diaphragm paralysis, which is one of the manifestations of neuromuscular disease. Now this tracing, it represents 4 hours of recording. There are long periods of continuous low oxygen saturation, as you can see, where the saturations drop down to less than 90%, and you see this episodic sawtooth desaturation at the middle and at the end of the tracing. And these both findings are very non-specific, and you can see it in other diseases as well. However, the continuous hypoxemia may reflect hypoventilation, low functional residual capacity, or the patient might be in a supine position. And this recurrent sawtooth pattern at 1.5 to 2 hour intervals, it raises the possibility of REM-related nocturnal desaturations from obstructive sleep apnea or from neuromuscular weakness. So these are the sawtooth patterns. And now quickly looking at the diaphragmatic 2-minute recording of a REM sleep in the same patient with right-sided diaphragmatic weakness. So this patient is in the right lateral positioning, and that might minimize the impact of the right diaphragmatic weakness. But you can see there are episodes of recurrent episodes of REM-related desaturations. Here you can see the SpO2. So there are recurrent episodes of REM-related nocturnal desaturations in association with hypopneas. These are the hypopneas you can see here. Now, all these events corresponds to the top 2 line, which is E1 and E2, which is eye movements in REM sleep. So these events all correspond to the phasic burst of eye movements in REM sleep, and they are associated with a greater reduction in the chest movements compared to the abdominal excursions. So abdominal excursions are pretty much good, but the chest movements are reduced significantly. And this is due to diaphragmatic weakness rather than pure airway obstruction, as you can see in child with adenotonsillar hypertrophy, for example. Now we will quickly look at the characteristics, sleep study features, and resolution options for disease-related sleep disorder events. Now for neuromuscular disease, when you think about sleep disordered breathing in neuromuscular disease, they are either related to the disease or they are related to the device. So we will look at what happens, what are the disease-related sleep disordered events. So you have pseudocentral events, hypoventilation, obstructive sleep apnea, and Chine-Stokes breathing. Now coming to pseudocentral events. So the most common sleep disordered breathing in neuromuscular disease, as we saw in the sleep study tracing, is hypopneas and hypoventilation with a sawtooth pattern of desaturation occurring during the REM sleep, representing early waning of respiratory muscle movement. So these are due to diaphragmatic weakness. You see the reduced chest movement relative to abdominal signal. And how do you resolve it? You increase the backup rate, or you increase the pressure gradient, which is your IPAP and EPAP difference, inspiratory and expiratory airway pressure difference. Now coming to hypoventilation. So when the neuromuscular disease progresses, we see hypoventilation. Now hypoventilation, as we have seen earlier, it is a combined effect of drop in lung volumes in the supine position we saw in the earlier diagram, correct? And then there is also a decrease in the ventilatory response to hypercarbia. This could be because of neuromuscular weakness or decrease in the chemosensitivity response. And how do you define hypoventilation? So in adults, it is defined as increase in your arterial CO2 by more than 55 millimeters of mercury for more than 10 minutes, or you have more than 10 millimeter mercury difference or increase in PaCO2 compared for 10 minutes. In pediatric patients, hypoventilation is scored as arterial CO2 or your PaCO2, which is greater than or equal to 50 millimeters of mercury for 25% or more of your total sleep time. So if your CO2 is more than 50 for a quarter of your total sleep time, that is hypoventilation in pediatrics. Again, what do you do for that? You increase the pressure support. You increase the IPEP, EPEP pressure gradient. And again, it corresponds to either low lung volumes or diaphragmatic muscle weakness. Now coming to OSA. So like OSA can happen in obese patients, it can happen in COPD patients, it can happen in patients with neuromuscular disease. And the risk factors for OSA in patients with neuromuscular disease remains the same. So usually there are male sex, obesity. In kids, you have adenotonsillar hypertrophy. However, in neuromuscular disease, your hypoventilation is primarily due to reduced respiratory muscle activity rather than pure obstructive events. And again, in the polysomnographic features, you will see the sawtooth desaturations, you will see worsening in REM, and you increase the EPEP for obstructive apneas, and you increase IPEP if you see more obstructive hypopneas. Coming to the last one, which is the central sleep disturbance in neuromuscular disease, which is Stine-Stokes breathing. It's either in association with cardiomyopathy, or it is due to an instability and control of breathing due to your diaphragmatic muscle weakness. An important differentiating factor between the Stine-Stokes breathing due to inability in the control of breathing is that your cycle length is greater than 40 seconds in heart failure. It corresponds to the prolonged circulation time. So if it is due to heart failure, your cycle length is more than 40 seconds compared to the diaphragmatic muscle weakness. And again, your resolution option is to treat the heart failure and acclimatization of the patient. So these are the characteristics of disease-related sleep disordered events in neuromuscular disease. And now we will quickly browse through the characteristics for device-related sleep disordered events in neuromuscular disease. And we will very quickly look at all of this. So first thing is air leak. And they're found in 35%, 1/3 of subjects undergoing NIV, and that can account for asynchronous such as auto triggers, and it affects the quality of sleep. And what are the resolution? How can you resolve it? You change the mask, or if the mouth remains open, you consider a chin strap to prevent air leaking out. Ineffective breathing. Now, what is ineffective breathing? It describes an effort to breathe without subsequent breath delivery in the NIV, in the non-invasive device. And this is the most common cause of asynchrony with NIV in neuromuscular disease patient, and it is found in 45% of cases. What can you do? You reduce the pressure support, right? Because this is an ineffective effort. Or you increase the trigger sensitivity so the machine doesn't give a breath at every small trigger. And you can also increase the expiratory PEP to combat the ineffective breathing. Auto-triggering is another issue. Auto-triggering refers to breath delivery from the non-invasive device in excess of the subject's respiratory rate. And this is most common in non-REM sleep, and it is associated with increased arousals. What you can do is you can adjust the mask, you lower trigger sensitivity, or you drain the circuit, because sometimes it happens, auto-triggering happens due to water condensation in the circuit. Other issue is prolonged insufflation. Now, what is this? It represents extension of breath delivered by the device beyond the subject's desired inspiratory time. So you are giving the breath for a longer period of time than it is required. Again, the resolution is to correct leaks and shorten the inspiratory time. Central apnea. So this is when the ventilation to a CO2, when you overventilate the patient, that the patient becomes hypocapnic. And the way to resolve it is to reduce the pressure support, right? Like, because you don't want to overventilate a patient. And the last one is glottic closure. Now, glottic closure happens due to adduction of the vocal cords. This is an exaggerated protective laryngeal reflex. And glottic closure occurs more consistently with controlled breaths rather than with spontaneous breaths. And what you can do is you lower the backup rate or pressure support in these patients, or you can trial a nasal mask and add some dead space ventilation to prevent the oropharyngeal obstruction. Let me see, yeah, 2 more minutes. I'm just going to summarize the American Thoracic Society consensus statement, sleep evaluation and recommendations. This is for the respiratory care of the patient with Duchenne muscular dystrophy. And ATS has used Duchenne muscular dystrophy as a prototype for all the patients with neuromuscular disease. So it's basically a consensus statement for all the patients with neuromuscular disease. ATS recommends to review sleep quality and symptoms of sleep disordered breathing at every patient encounter. They also recommend annual evaluation for sleep disordered breathing should be performed in patients with Duchenne muscular dystrophy, starting from the time they are wheelchair users and or when clinically indicated. So you should start evaluation for sleep disordered breathing or SDB as early as you can. So when available, you should do an annual polysomnography with continuous CO2 monitoring is ideal. So if available, annual sleep study with CO2 monitoring. Now in areas where you don't have access to full polysomnography, overnight pulse oximetry, again with continuous CO2 monitoring, can provide useful information about nighttime gas exchange. Although sleep disordered breathing not associated with desaturation or CO2 retention will not be detected. So it's very important to have a full PSG with CO2 monitoring. And a simple CBG or capillary blood gas upon arousal in the morning can demonstrate CO2 retention, although it's not as sensitive as continuous capnography. Use NIV, so nasal intermittent positive pressure ventilation, to treat sleep-related upper airway obstruction and chronic respiratory insufficiency in these patients. Negative pressure ventilators should be used with caution because they can precipitate upper airway obstruction and hypoxemia in these patients. Do not use oxygen to treat sleep-related hypoventilation without ventilatory assistance. And I think Dr. Haqqani stressed on the same point for his obesity hypoventilation syndrome. Oxygen is not the remedy for all sleep disordered breathings. Consider daytime ventilation. So you should also consider the daytime ventilation when your waking PCO2 is more than 50 or when your saturation remains less than 92% while the patient is awake. And in centers with appropriate expertise, consider mouthpiece intermittent positive pressure ventilation or other forms of non-invasive daytime ventilation. Consider tracheostomy when contraindications or the patient is aversive to NIV or when NIV is not feasible due to severe bulbar weakness or dysfunction. I'm sorry, I took a little longer time. I'm happy to take any questions.
Excellent. Well, thank you very much, Dr. Rizwana. And please, if you have any question, type it on the Q&A chat box. If you have any other question related to NIV in neuromuscular disease or obesity hypoventilation, otherwise, if there are no questions, then we can move to the third talk. Well, again, thank you, Dr. Rizwana. And now I'd like to introduce Dr. Deepa Grandon, who's a clinical assistant professor of medicine at Case Western Reserve University, Cleveland, Ohio, who will be talking about severe asthma characteristics. Please welcome Dr. Deepa.
Yeah, hi, sorry. Just a minute to mute over here.
Sure.
Mohammed, can I ask a question while Dr. Adib is getting ready?
Please, please.
Why is it that non-invasive positive pressure ventilation shows some mortality benefit in restrictive lung diseases in general, as opposed to obstructive lung diseases, such as COPD? Or does this statement hold true?
You say it showed a mortality benefit, mean reduction mortality. Is that
correct? If somebody has respiratory failure, hypercapnic respiratory failure due to restrictive lung disease, such as non-parenchymal lung disease, such as neuromuscular disorder, the non-invasive positive pressure ventilation saves their life, as opposed to somebody who has parenchymal lung diseases. When you use non-invasive post-pressure ventilation for hypercapnia due to parenchymal lung disease, the benefit is not really, studies have not shown mortality benefit. Do you agree?
Sure.
Is this a correct statement, and why is that?
Sure. So I think Dr. Rizwana did explain some of the physiology, and we went through it. So the neuromuscular disease, they have issue more with ventilation rather than oxygenation. And most of the time, their CO2 is high of more than 45, and therefore you need something to help them ventilating with improving the tidal volume and minute ventilation. Versus patients who have parenchymal lung disease, most of the time, they're not a CO2 retention, they're not hypercapnic. Their issue is with BQ mismatch and more of oxygenation. So giving them an IV, it would not be indicated if their CO2 is within normal, and most of what they need, especially we're talking about interstitial lung disease, they need oxygenation rather than ventilation. So the physiology is totally different, where so that the patients you're talking about with parenchymal lung disease, they have no issues with ventilation, their issue is more with oxygenation.
Thank you.
Well, thank you. Okay, now is Dr. Adiba ready?
Yes, I am. Thank you. So thank you, Dr. Holkani, for my introduction. I'm Dr. Deepa Grandin. I'm an allergist immunologist at the Cleveland Clinic in Abu Dhabi. And I'm going to take some time to just talk about characterization of severe asthma. So I'd like to start off my talk with discussing why it's important to characterize severe asthma, even though they form pretty much a minority of our population. So to just throw out some numbers over there, the most recent data I could find about prevalence of asthma in general in the UAE was roughly around 4.9%. So if we look at our current population, which is roughly around 9.6 million, you're talking about around 470,000 some individuals with asthma. And when we take our asthmatics and look at our severe asthmatics, they are roughly around 3.6 to 4%. So you're talking about 16,000 some individuals. But these individuals, while they are a minority, they have a huge economic impact on our healthcare system, just because it's so difficult to control them, and they're constantly in the emergency room or hospitalized in the ICU or in general wards trying to be controlled. So it's important to understand what's the best way we can help these individuals stay out of the hospital and also stay off of these highly anti-inflammatory medications, especially your steroids that have so many side effects. So it's good to understand what is the underlying pathophysiology so we have a better way of treating these individuals and addressing it in a manner that's more like individualized medicine as opposed to one size fits all. So you might have heard the term uncontrolled asthma, difficult to treat asthma, severe asthma, all thrown around as to mean the same exact thing, but they're really not. There are certain nuances between these three that we do need to understand. So when people are using these terms, we have a better understanding of what exactly they're trying to say. So when you're looking at somebody and you're saying, hey, this person has uncontrolled asthma, what exactly do you mean? Besides the fact that, yes, their symptoms are poorly controlled, meaning they have to use their reliever medication a lot, or they're having frequent exacerbations. And, they've been given steroids quite a bit. And sometimes they've been so sick, they've had to be hospitalized. So yes, we get that. But when we go into the underlying cause, right? First off, is the patient even taking their medications? Why are they not taking their medications? Are they using their inhaler in the right manner? Have you even watched them using their inhaler? And then, do you have the right diagnosis? Because we know that not everything that wheezes is asthma. We've had some really great talks about obesity, hyperventilation. And then we've also seen patients who come in, maybe they've actually got vocal cord dysfunction and they're wheezing, or they have COPD. Again, there's so many reasons why these individuals can have chronic cough. They can be wheezing. It's not always only asthma. So first, do we have the right diagnosis? 2, is the patient really taking what they're supposed to take? So all of these can constitute uncontrolled asthma. So we don't want to just throw out the term severe asthma just because a patient's uncontrolled. We have to make sure, first off, if we have the right diagnosis, patients taking their medications, have we identified all their comorbidities, like for instance, acid reflux, sleep apnea, like our earlier speakers were talking about. All of these have such a huge impact on patients' breathing physiology that it has to be addressed, or their asthma is not going to be well controlled. And if these comorbidities are not addressed, technically it's not severe asthma. Then let's talk a little bit about difficult to treat asthma. So your difficult to treat asthma, yes, your severe asthmatics are going to be difficult to treat, but there is a slight difference between your difficult to treat asthma, because in these individuals, you can actually gain control if first you've addressed all their comorbidities, made sure they're taking their meds like they should, and their technique is correct. And then you'll find out that this specific population of individuals, they are in your GINA step 4 or 5. And what does that mean? They are using medium to high dose of inhaled corticosteroids with a second controller, which could be a LABA, it could be a leukotriene modifier, it could be theophylline, or they're using maintenance oral corticosteroids. But you can achieve good control with these medications in your difficult to treat asthmatics. It's just that they need all these medications to be controlled. And then you come to your severe asthmatic. And your severe asthmatic is basically your combination of everything. That means that you've taken care of all their comorbidities. They are on GINA step 4 and 5 treatment. But in spite of that, you're struggling trying to control these patients. Now, these are genuinely your severe asthma patients. So by definition, they can have either one or both of the following levels of treatment requirements. And in spite of that, they can remain uncontrolled. And how do you define uncontrolled? Meaning they have poor symptom control. When you take your asthma control questionnaire, they're consistently greater than 1.5, or your asthma control test is consistently less than 20. And they keep requiring these frequent glucocorticoid steroid bursts. Sometimes they are in the ICU. So, you get the idea. And just to briefly touch on what exactly defines high doses, so you can see depending on the steroid that is being used, you have these different numbers. For instance, the beclomethasone for 6 to 12 years of age, anything greater than or equal to 320 for your hydrofluorocline or your meter dose inhaler. And for those who are older than 12,000 micrograms per day of the hydrofluoroalkane or the meter dose inhaler. So you can just go down that table and see, these individuals, they need to stay on this. You try to bring them down and then they flare up and, have to be on oral corticosteroids. So coming back to the rationale, why do we need to characterize asthmatics? Because it's not a homogeneous disease, meaning there is so many different pathologies underlying this disease that's the reason why different patients respond differently. They don't all respond to the same medication. And, for the longest time, we were just using inhaled corticosteroids or oral steroids. And a lot of times there is this minority of patients, they just don't respond to this kind of treatment. So trying to understand why are they so different it's an important part of what we have to do as physicians. So coming to the cluster analysis. So there have been many studies that have been published over the years. And I'm just going to touch on some of the more popular ones. One is the UBioPred paper that was published. And this was a European study. And what they did is they classified or grouped patients based on 8 pre-specified clinical physiological variables. One was age of onset of asthma symptoms. 2 was pack years of cigarette smoking. 3 was their BMI. 4 was their forced exhaled volume in 1 second as a percentage. 5 was their FEV1 FVC ratio. 6 was the average score of the 5 questions of the ACQ. 7 was their self-reported number of exacerbations, and 8 was their daily dose of oral prednisone or some equivalent to that. And what they found is they came up with 4 clusters. And these clusters, according to them, were reproducible and quite stable. All right, so now clinically and physiologically, they were able to cluster them. So they went a little bit deeper to see, are there any sort of biological ways of identifying or to see if these clusters would remain true to themselves? So they did sputum proteomics and transcriptomics, and what they found were the severe asthma clusters 2, 3, and 4 were a little bit more similar in that they had very high sputum eosinophilia compared to T1. But when they tried to compare this sputum neutrophils, exhaled nitric oxide, and serum IgE, they were all over the place. So they were not very clear cut. Another cluster analysis that was done by the Severe Asthma Research Program in the US, around 726 asthmatics were analyzed. And they came up with 4 clusters as well. So their cluster 1 were individuals who had early onset, like childhood onset of atopic asthma. And these were probably the easiest of all the severe asthmatics for them to control. And they had 2 or fewer controller medications, minimal healthcare utilization. And their cluster 2 consisted of early onset atopic asthmatics with preserved lung function. But these individuals required more medications to keep them out of the healthcare system. And then here, cluster 3. Now, this was a unique group. They were mainly obese females with late onset of asthma, mainly non-atopic, required a lot of corticosteroids to keep their exacerbations out of the way. And then they had the clusters 4 and 5. And these individuals had a lot of airflow obstruction, bronchodilator, and their bronchodilator responsiveness kind of varied between the 2 groups. So taking all the different cluster analyses that have been done over the years, we've come to understand at least there are these few clusters of individuals that you can put them in these little buckets and then try to see, hey, you know, these patients who present like this, they respond well to this type of treatment. For instance, now when you look at the slide, you can see the very first one that says childhood onset of allergic asthma. So what exactly is childhood onset? Meaning they've developed asthma before the age of 12. Now, this is the most homogeneous group, meaning they had most of these individuals that fell in this group, they had a family history of allergies and asthma. And these individuals also, they responded really well, preferentially pretty well to like the anti-IgE, for instance, your omalizumab. Now, your second group, which is your adult onset atopic asthma. Now, adult onset, technically, based on most of the definitions, is after the age of 12, okay? Most individuals who develop asthma after the age of 12, they tend not to be allergic, but there is a minority of patients that are, and a lot of these individuals who develop asthma after the age of 12, they typically have a childhood history of allergic rhinitis or sometimes even eczema, and then over time they did develop the asthma. Now, there was a study published in 2013 by Sally Wenzel's group called the EXTRA study. And these individuals actually did really well on omalizumab. And what they found is more than the IgE levels, what correlated with their response to treatment were the Th2 inflammatory markers. For instance, your exhaled nitric oxide, your blood eosinophils, your serum periostin. The higher those numbers were, the better these patients did or responded. Now, the adult onset non-atopic asthmatics, a lot of these individuals will come with a history of saying, you know, I had this viral illness and all of a sudden my breathing is shot. I can't like really breathe, you know? Or they'll be like, oh, I'm a baker, or I work in the oil fields, or some sort of occupational exposure, or, you know, I took aspirin because I had, you know, some sort of an MI or whatever that they had to be exposed to aspirin. And then something happened and they had to have, they noticed that their breathing was really bad. So this is kind of like the history you're going to get in those adult onset non-atopic asthmatics. You don't really hear this kind of history from your pediatric population that had it when they were children. So next would be the hypereosinophilic. Now, this is actually a very interesting group. They have a kind of like an overlap. They're not very pure in how they manifest. because a subset of these patients have eosinophilic asthma that requires systemic glucocorticoids. And there's also like 30 to 70% that are atopic, but the majority also can be non-atopic. So they're kind of like mixed, and their inflammatory pathways are like all over the place. Now, when you're looking at AERD and you're talking about asthma exacerbated respiratory disease or aspirin exacerbated respiratory disease, they're usually a combination of asthma, chronic rhinosinusitis, nasal polyposis, involvement of upper and lower airways. And the basic underlying pathology is their dysregulation of the arachidonic acid metabolism. So you can see that these individuals genetically, they just make a lot of the leukotrienes C4, D4, E4, which are very pro-inflammatory. They take aspirin or any of those NSAIDs, and it further increases the production of these leukotrienes, and hence they have an exacerbation of their asthma. And these individuals, you know, you can do like the aspirin desensitization, depending on the safety that you have to keep in mind. And also in monoclonal antibody dupilumab, which is your interleukin-4 receptor alpha blocker, also these individuals tend to do pretty well when they are given this. But I don't want to take too much away from Professor Emilio's talk, because he's going to be talking more about specifically the treatment. But I just wanted to, you know, kind of briefly show you that aspect where asthma is not, as much as we like to put them in these neat little buckets, it's not going to happen. They do have a lot of overlap between the different phenotypes. Now, the next group, which is your asthmatic granulomatosis, it's been very fascinating for me because I personally have not seen too many of these types of patients, but I have read about them. And so this is a subset which has who have interstitial non-necrotizing granulomas. And granted, like the only way you can really identify these, the study that was published, and this paper was published in 2012 in the American Journal of Respiratory Critical Care. The only way they were able to identify these patients, they needed video-assisted lung biopsy. And what they found is they had these really unexpected non-necrotizing granulomas, along with the asthma picture, which is your submucosal inflammation and your mucus plugging of the small airways. And none of these individuals had evidence of hypersensitivity pneumonitis, but had very high blood eosinophilia. Also, their FeNO was elevated. And a lot of these individuals also had atopy. But the most interesting part about these individuals, 70% of them had a personal or family history of autoimmune-like disease, and they actually responded really well to immune suppressants like azathioprine, mycophenolic acid, methotrexate. So, you know, keeping this in the back of your mind, and that's the reason why, you know, imaging your patients that come in with shortness of breath and cough is always very important. And that's like such a simple evaluation, doing a chest X-ray, and a lot of times we miss it. Oh yeah, this patient just has asthma. They come from another physician. Yeah, this patient has asthma. Let's like not do anything else, right? No, at least get a chest X-ray. You see something, you know, suspicious, you can always do the high resolution CT, make sure there's nothing else going on, because even sometimes bronchiectasis can be missed in some of these patients. All right, talking about asthma associated with obesity, and I think the speakers that went before me spoke very well about, you know, how obesity can play such an impact on patients' breathing. And in 2008, a paper came out of Netherlands, and they looked specifically at obesity and asthma. And the funny thing about this was, as much as they wanted to blame it all on the fatty tissue, the individuals that did succeed in losing weight, their asthma did not like, you know, significantly improve like we would have liked it to be. So obviously there's a lot of other inflammatory pathways that these individuals struggle with that we probably don't have a complete understanding of how the two are linked. Okay. Now, the perimenopausal onset of asthma. Now, I just gave them a different category just because they are also an interesting group. Okay, so when you're defining somebody as being perimenopausal, this is, or perimenopausal onset of asthma. It's basically onset of asthma within a year of a woman's last menstrual period. So the paper that was published in 2009, Clinical and Experimental Allergy, it actually showed that females have a higher risk of developing non-allergic asthma later in life. And these women, and this was another paper that was published in 2010, and what they found in these menopausal women, they have decreased estradiol concentrations and much higher sputum neutrophils when compared to premenopausal females. So while they could possibly fit into your adult onset non-atopic asthma, there is something about the female hormones and the lung physiology that, you know, they don't match up with their male counterparts. So they're kind of like in there a little bit differentiated. All right, so I'm just going to say briefly a little bit about unique clinical characteristics that we see in severe asthma. And it's not like it's only to one specific phenotype, because most severe asthmatics, regardless of their phenotype, they show these characteristics. And so when you think about glucocorticoid resistance or glucocorticoid dependence, what exactly are we talking about? So we all know that steroids are highly potent anti-inflammatory drugs. And the response to treatment in this particular category of patients is across the board. I mean, sometimes you have to give them way more than you would like to. And that's because there's almost a shift in the response in the receptors, and they like require much higher doses. And yeah, so this is one of the unique characteristics that you will see in most of your severe asthmatics. And in patients in general who have the higher eosinophilia, in especially the sputum eosinophils, they tend to do better with it. But sometimes we don't know which came first, especially when you're looking at neutrophils. You don't know if it was because of the steroids that they are having more neutrophils, and then they're not being very responsive on top of that. Now, looking at frequent exacerbations. Now, some severe asthmatics, more than others, tend to exacerbate. Now, what exactly classifies a frequent exacerbation? Nobody really knows exactly, but most papers, they say around 2 to 3 exacerbations a year can be classified as frequent exacerbations, and around 30% of severe asthmatics have a tendency to do this. And these individuals, when you look at them closely, they have a greater peripheral area obstruction, persistent eosinophilia, and usually they have other forms of comorbidities like chronic rhinosinusitis, obesity, obstructive sleep apnea. So, you know, and all the more reasons to make sure you're addressing all those other comorbidities. So I guess nobody here is a stranger to the adverse outcomes of steroids, and that's the reason why when we try to phenotype these patients better, we can actually treat them and try to get them away from steroids, because steroids, as we know, can cause quite a bit of a havoc on these patients. All right, just briefly touching on biomarkers. So now, you know, when I did the phenotyping based on clinical physiologic characteristics, and then yes, we did touch a little bit about the biological aspects as well. But we know a lot more about our T2, which are your T helper 2 lymphocytes. And identifying these biomarkers for the various asthma phenotypes really makes a huge difference when it comes to selecting and individualizing treatment. So patients with your high levels of T2, obviously they do a lot better. And right now, you know, we have so many treatments which target these biomarkers. So they're T2 targeted therapies, which are considerably more efficacious if you can choose the right candidate. So T2 inflammation, so we have the T2 high, and then we have the non-T2. So the T2 high is actually almost 50% of our severe asthmatics, thankfully, because we actually have something to give them. And then if you look at the T2 inflammatory pathway, you're looking at eosinophils, mast cells, basophils. You also have your group 2 innate lymphoid cells, which kind of sits in the middle and has some overlap with your non-type 2s. And anyway, when we can identify patients in a manner where if they have high eosinophils, high FeNO, high serum periostin, which, you know, it's kind of hard to do. We don't really have good access to that. But if you're able to identify these individuals and putting them on the right treatment, it's so invaluable, because the eosinophilic phenotype, especially in your late onset asthmatics, they actually do pretty well with your anti-interleukin 5 and also your anti-interleukin 4R alpha, which is your receptor blocker treatment. So yes, so trying to identify using biomarkers. For the longest time, we're just using clinical characteristics, physiologic characteristics, but using the biomarkers is so useful, especially if you can use blood eosinophils, exhaled nitric oxide. This helps us to identify which patients to put on specific treatments. Fractional exhaled nitric oxide. So when you have a FeNO greater than 50 parts per billion in an adult and 35 parts per billion in a child less than 12, that usually indicates lower airway inflammation. Paper that was published in 2012, Clinical Experimental Allergy, that's Sally Wenzel's group. They actually looked at bronchial brushings and sputum from severe asthmatics, and they compared it to mild to moderate just to see, you know, can we actually tell a difference? And the expression of inducible nitric oxide synthetase, this is the enzyme that actually generates exhaled nitric oxide, was significantly higher in the severe asthmatic group. Another study that was published in the Journal of Clinical Immunology in 2014 again showed that FeNO was actually a better predictor of systemic steroid use among patients with severe asthma than just their FEV1. Now, again, FeNO has its issues. It's not, you know, like this perfect test, like all asthma tests. We don't have a perfect test, so you always have to take it, you know, with a grain of salt and with the whole picture. All right, so neutrophilic asthma phenotype, around 40 to 60% neutrophils in the induced sputum puts you in that category of neutrophilic asthma phenotype. And there's a lot of controversy around this because several factors can contribute to neutrophilia. For instance, just taking your inhaled steroids, air pollution, being sick, sensitization to aspergillus, reflux, all of these can contribute to neutrophilic asthma phenotype. And in the severe asthma research program, they actually identified 2 subgroups. And the group that had like a mixture of your neutrophilia and your eosinophilia, they were actually the more sicker individuals who are more difficult to treat. So I did talk briefly about periostin. So periostin, while it seems like a very promising biomarker, to date, we've not been able to very easily implement it in our clinical setting. It's an extracellular matrix protein, which is encoded by the gene postin. And there have been studies looking at microarray of the area epithelium, and it's almost 4 times higher in your severe asthmatics, so who have the type 2 type inflammation. So if there was like an easier way for us to actually measure the periostin, that would be a really good way of identifying a T2 high asthmatics. So okay. So anyway, I'm just going to end by saying phenotyping, as much as it will help us, it's still not a very clear-cut way of identifying. So just, but it still is useful and worth looking into. Thank you, and I'm very sorry for going over.
It's okay, and I think we have few questions. If you go to the chat, and one of the questions I can see here from Dr. Asania, she's asking about asthmatic granulomatosis, and she said, does you mean broncho or endobronchial? And what would be the rule of transbronchial biopsy?
All right, so as far as the asthmatic granulomatosis, it's actually its own entity. And like I briefly touched before, it was a surprising finding for the researchers who actually identified this group of patients. And one of the things that they did find when they were evaluating them was they did not have anything, like I said before, it does not fit into your hypersensitivity pneumonitis type cases. And they were interstitial, non-necrotizing granulomas. And the way they did the biopsy, I'm not sure of the exact detail of what mode of biopsy was taken, but it was a video-assisted lung biopsy. And what they found was it was interstitial and it was non-necrotizing.
Okay, well, excellent. Well, thank you very much, Dr. Adiba. We really enjoy your talk. And now moving to the last but not least, Professor Emilio, who will be talking about predictive biomarkers in severe asthma. Professor Emilio is a professor of respiratory medicine and head of the Asthma and Airway Inflammation Center.
Thank you, Dr. Al-Ghani, and thank you, the others. It's a very good pleasure to me to participate in this ETS meeting. So I am Emilio Pizzichini. I am a professor of respiratory medicine. It's an island in the south of Brazil called Florianopolis. Those are my conflicts of interest. So I am an employee of GSK, part-time, and I have been asked to speak about biomarkers. So that Dr. Grupa just mentioned in the previous talk about severe asthma. So I had decided to divide my presentation in 3 topics that are: why are they relevant, the eosinophilic phenotype, and a little bit about the role of anti-IL-5 in this condition. So I think a biomarker is important because, as stated before, with the use of biomarkers, we understood that asthma is a heterogeneous and complex disease. So we don't have a homogeneous disease, we have a heterogeneous disease. And this is any molecule that we are able to measure. The age of that we are measuring right now is the phenotype areas, where we have a biomarker that can be related either to environmental factors or background factors and related to the pathophysiology of the disease. And actually, we are looking forward to moving to the era of endotyping, where we are able to understand what is the pathophysiological mechanism of the condition. So in this cartoon here, we understand that we have clinical phenotypes that have been addressed just before, like asthma associated with obesity or allergic asthma in childhood. But in many situations, we still don't have homogeneous conditions if you want to go down to the molecular phenotypes. And the molecular phenotypes that we have so far are eosinophilic and non-eosinophilic asthma. We do like to tell this non-eosinophilic because not all non-eosinophilic asthma are actually neutrophilic asthma. Actually, when you measure a sputum for assessing airway inflammation, you are going to see just a minority of the patients have more than 65% of neutrophils into the airways, characterizing neutrophilic asthma. And what we want to reach in the future is actually understanding what is the endotype that's involved in our patient. So it's IgE, that's the main endotype, IL-4, IL-5, 13, or others. This cartoon tells us what the majority of the trials that have been addressed investigating the role of monoclonal antibodies, like we can see in the right here, have used 3 biomarkers: IgE, blood eosinophils, and FeNO. And if you see about the size of the node that you see there, the one that is bigger, and it has been a common link within the monoclonals that affect allergic asthma, non-allergic asthma, its blood eosinophils. And we are going to tell you a little bit about this. Periostin has been addressed beforehand, unfortunately, with the trial of lebrikizumab, that is an anti-IL-13 antibody, and where periostin would be a very good biomarker for that situation, has been negative for proceeding in clinical trials. Those are the biomarkers that we use in clinical practice according to GINA. So blood eosinophils higher than 150, FeNO higher than 20, sputum eosinophilia higher than 2%, allergic driven condition is very important, and unstable asthma when you drop down the dose of ICS or oral steroids. So those are the phenotypes. And based on these phenotypes, when we find someone that is eosinophilic or type 2 high inflammatory, we can search about the monoclonal antibodies that we have for use in this situation that are anti-IgE, anti-IL-5 or anti-IL-5 receptor, and anti-IL-4/13 antibodies. And according to these factors, we are going to see that these responders are going to be mostly the ones that have type 2 high inflammation into the airways. This is a cartoon about the phenotypes of biologicals used in a population of severe asthma in northeast of Brazil. So this paper is from Álvaro Cruz, which is a member of the GINA Science Committee, and he has raised the prevalence of asthma that was sensitive to omalizumab, mepolizumab, reslizumab, and benralizumab. When the research was done, that was a year ago, dupilumab was not available in our country yet to be treated. So, and then you can see that the vast majority of the patients, they are going to share a niche either for mepolizumab and omalizumab and less for reslizumab and benralizumab. So the second point that I would like to address is the importance of the eosinophilic phenotype. And even though for many years asthma has been considered a condition that has eosinophilic inflammation into the airways, the first trials of monoclonal antibodies against IL-5, all the trials that have been negative. It was not until this trial has been developed. Back in Canada, when I was working at McMaster University, we select 19 subjects that have a very homogeneous conditions. They were severe asthma. They had exacerbations. That was the main complaint that they had. They were all dependent of prednisone to be maintained in the best control. And we decided to do a trial to investigate 4 questions. If you give to them an antibody against IL-5, in that situation was mepolizumab 750 micrograms IV, can we decrease exacerbations? In those patients that are using prednisone, can we decrease prednisone, spare prednisone, and still in this situation maintain asthma control? Finally, can we see the plausibility of these drugs decreasing inflammation either in the blood or in the sputum, and also improving patient-reported outcomes? And the answer for all these questions was yes for all the conditions. So there were 12 exacerbations in the placebo group and 1 exacerbation in the mepolizumab group, and this exacerbation was non-eosinophilic, was not treated with oral steroid. There was a 50% reduction in the dose of oral steroids, eosinophils in blood were reduced 80%, and they were followed in the sputum again, and there was an improvement in FEV1, even though we had a decreasing of the oral prednisone by 50% in 300 mLs. So actually, that study pushed at the time GSK to do a randomized clinical trials to assess first the dose and the efficacy of mepolizumab. And the DREAM study assessed this question. It has shown that you are able to decrease exacerbation more than 50%. But another important question in the DREAM study was to investigate what would be the best biomarker that the patients could be used in clinical trials. So when they designed the study, these patients would enter the study if they had blood eosinophils higher than 300, sputum eosinophils higher than 3%, exhale NO higher than 50. They had a deterioration of the clinical picture if they had a deterioration with a reduction of 25% in the dose of ICS and OCS. And the question that they had, if I do this, can I find which is the best biomarker in this population? And those are the results that the study gave to us. So a pre-specified analysis to understand what was the best biomarker. Sputum blood eosinophils higher than 150 or 300 were more likely to predict a good responder than the others. Sputum eosinophils did fail in this study because it has been assessed in several centers that they did not have experience measuring sputum inflammation into the airway. So if you don't have a reliable method, the method is not going to give you good results. FeNO was not a good biomarker, and also they tested A2P and bronchodilator response. That was also not a very good biomarker. In this situation, they also asked the question in relation to the blood. So the patients that entered the study, they should have a history of 300 or more or other features. And when they did this analysis, they understood that to observe a 30% reduction in exacerbation that was thought to be meaningful for these patients, you observe a reduction that was higher, 30% or higher in the exacerbation rates if the eosinophils was 150. After all these studies, all the cut points for eosinophils in the MAPO study have been 150. What the study also addressed was the question about, does blood eosinophilia tell us anything else about this? And it's a very good biomarker in a way that we can predict the response to biologicals. The higher are the concentration of eosinophils in the peripheral blood, the higher is the response. So go from 53 when the cut number is 150 and goes to 73% reduction when you have more than 500 cells. The vast majority of the patients that we see in clinical practice in real life are within 400 or over here. So we see a reduction in exacerbation that are 50% or over. They also asked the question if the amount of the eosinophils in circulation, and this has been done in the past also, was a marker of severity of the disease. And analyzing outcomes that could relate to severity of disease, they found out that there was no relationship between the proportion of eosinophils and the severity of the asthma. So eosinophils in the peripheral blood is a marker of responsiveness to an intervention. So a very good responsiveness biomarker, but it's not related to the severity of the disease in that condition. So I think with this data, and also with the flow of the data that we see with all the biologicals, at the present time that we don't have an endotype, blood eosinophils are very useful biomarkers because they are readily available, they are cheap and fast to obtain the results, and they are highly predictive to estimate the response to biological treatment in these patients. Finally, I'm going to share some information about the role of anti-IL-5 mepolizumab in the eosinophilic phenotype. This cartoon shows the effects of mepolizumab in the cardinal studies that have been submitted to FDA and EMEA in a way to have mepolizumab approved for clinical use. You can see that in relation to exacerbations, the Mensa and the Musca study show that if you have more than 150 eosinophils, you are going to see reductions that are over 50%, 53 and 58%. And the results are very consistent with each one of the studies that have been performed for randomized clinical trials and also in studies in real life. In a patient with steroid prednisone-dependent asthma, you are able to reduce the dose of oral steroids in 50% in a short period of time, usually 6 months, and there is more than one study supporting this. Also, with quality of life, if you use the St. George questionnaire that has been developed to assess quality of life in patients with severe asthma, admitted patients in hospitals with severe asthma, you see that the improvement in quality of life is very high in this situation. It's twice as much as the minimum important difference. And this is the only biological that has a study showing clinically important improvements in quality of life. And you also are going to have improvements in patient-reported outcomes as asthma control and FEV1. So we have data to show the evidence with mepolizumab. It's the first-in-class drug to treat eosinophilic asthma, the most selling drug in the world to treat severe eosinophilic asthma. Has a length of data that has consistent to show efficacy. There is data showing long-term safety and data from real-life studies conducted around the world with this. I would like just to make a few statements in relation to the overlap that we in many situations have between allergic or IgE-dependent asthma and eosinophilic asthma. So there is a lot of patients that they are either eosinophilic and also atopic. And in this trial here in the Mensa and the Musca study, we have evaluated actually if the patient was omalizumab eligible or omalizumab ineligible. If there would be a difference in the response to mepolizumab in that situation, and there was no difference between eligible or ineligible patients. We also look about other outcomes that could predict a better response to anti-IgE or in relation to anti-IL-5, and we will rank it according to the level of IgE in these 4 topics, and the allergic status, yes or no, and in relation to the number of allergens that they have been positive in the skin prick tests. And there was also no difference in the responders and non-responders if the patients had eosinophilic asthma, meaning that they have more than 150 eosinophils. And this was also true in relation to the presence of nasal polyps and also ARD. So showing the answered that if you are eosinophilic, doesn't matter if you are aspirin sensitive or not, but you are more likely to respond to anti-mepolizumab if you have nasal polyps, and then the reduction rate in exacerbation in this post-hoc analysis was 85%. And when we look to the data from anti-IgE, and this is the extra study that has been addressed before, but there was a review after that that was conducted by Nicholas Hanania from US, where he compared the response between mepolizumab and placebo in relationship to biomarkers. And what he was able to understand that if you divided patients with omalizumab lower than 260, the response rate was 90%. If it was higher than 260, it was 32%. And that is the reason, because nowadays in the GINA guidelines, they also suggest omalizumab in patients that have eosinophilia into the airways. And this, in the other side, you can see the response with those cut points for mepolizumab, and the response is 61%. We see that with mepolizumab, we have a reduction around 80% of the eosinophils. With omalizumab, we do not have a striking reduction of eosinophils. And this is different from one and to other, and in the same way that there is no reduction in IgE in that population. I think one of the important points that I take into account to speak about the effects of this treatment is about quality of life. Unfortunately, the St. George is a too lengthy questionnaire to be applied in clinical practice, and we should have a better outcome to measure quality of life to assess the effects of biologicals in clinical practice. Finally, after this, I would like to go to my conclusions. And I would say that if you have eosinophilic asthma and the cut point is 150, you are going to find that with mepolizumab, you have a very predictive biomarker to tell you that we are going to see a reduction in exacerbations. And also, you are going to see reduction in other, or improvement in other outcomes like prednisone dose, improving FEV1, and decreasing improvement in quality of life. Eosinophils, even though it's not the best biomarker, and I think we are going to have best biomarkers in future, for today is the best one that we can have because it's cheap, widely available, and easy to interpret in these situations. With this, I would like to thank you very much for your question, for your participation. Salam alaikum, and I will be able to answer some questions if you have.
Well, thank you very much, Professor Emilio. It was really a very interesting talk, and showing again the biomarkers and the phenotyping, and now you also went through the treatment with anti-eosinophils. Now it's open for the audience. If you have please any questions, feel free to type it on the chat under Q&A. And so far, I don't see any. Okay, so I have a question here from Dr. Riyad. He's asking, is total IgE considered as a marker for type 2 inflammation?
Well, IgE, I think, is a marker of the dose of omalizumab that you are going to give to your patient. Actually, with the IgE, you are not able to demonstrate that the higher the IgE, the higher is the response to omalizumab. So it is independent if the level is around 50 to 3,000. And also, I think there are reports about IgE about the use of omalizumab with good response in patients that are not IgE dependent, so that they have non-atopic asthma. Maybe the explanation for this to me is that I think the most important topic to assess there, it would be the local expression of IgE in the tissues that are involved. So we see sometimes that the expression of IgE within the airways, and in the past we have measured IgE in the sputum patients with allergic asthma, and this does not correlate with the IgE that we measure either with prick tests or with serum measurements. So this is my interpretation about that, but maybe Deepa has another option for this.
Okay, now the second question is asking, is there an increase in infection rate with anti-IL-5?
So that's a good question to be answered, because we understand nowadays that eosinophils are not only a cell that can cause harm to you, and that is increased in eosinophilic inflammation like T2 high, but also eosinophils are an important cell in the innate immune response. And there is a report done, I think in the beginning of this year, or 4 cases with patients being treated with anti-IL-5 drugs, and 3 of them with benralizumab and 1 with mepolizumab. So in the mepolizumab one, there was occurrence of infection by fungus in that situation. And in the 3 cases with benralizumab, there was infections with those situations. So another observation is that the likelihood to have exacerbation when you are treated with benralizumab, you are more likely to have exacerbation that are non-eosinophilic. So they are non-Th2 responsive in relation to the others. And the situation that we can raise here is in relation to the mechanism of action of different drugs. One is about the ligand IL-5, and another one is in relation to the receptor, which is IL-5. And in that situation, when you block the receptor, you are maybe causing increased that cell rates and antibody against those cells, and you can decrease the immune response in that situation. But this is still to be investigated. There is just few reports, but I think it's very important to classify the nature of exacerbation in a way to assess if it's eosinophilic or non-eosinophilic.
Interesting. And the last question from Asthma, she's asking, does IgE level has a role in diagnosis of eosinophilic asthma?
Now, to me, IgE has stated in GINA, IgE is not a biomarker. So to classify a patient as allergic or non-allergic, you base this on skin tests or blood tests that you measure specific IgE. Mm-hmm. Okay, the IgE is related to history of asthma, and it's also related to the loss of lung function with the age. However, it's not a biomarker that is specific for allergic asthma. I think the most important thing that we need to have in patients with asthma is to assess the nature of disease. So with skin tests and also with a very specific history about an allergic driven situation in this patient, which is very, very important to characterize allergic asthma.
Okay, and well, I was about to conclude, but here's one more question. No, I don't think it's a question. Someone is saying he's Dr. Riyad using dupilumab to treat the chronic. Sure, that's nothing to do with. Is there any expected increase in infection? We did answer this. Yeah. So, what's your experience with chronic rhinosinusitis and nasal polyps?
So, with mepolizumab, Nucala, there is trials that shows that if you measure this NOT questionnaire in patients with nasal polyposis, you are going to see increase in this decrease in this NOT questionnaire that is with a score higher than 9 units, which is the minimum important difference. A study has been published and presented in DRS in relation to the efficacy in chronic rhinosinusitis with nasal polyposis. And the study was positive for all the outcomes. However, mepolizumab is still not approved for use in nasal polyposis or chronic rhinosinusitis. With the data that we have in mepolizumab, however, if you have a nasal polyposis in your history, you are much more likely to respond to mepolizumab than if you don't have a nasal polyposis. So it's a very interesting situation to investigate nasal polyposis, because in the vast majority of the patients with nasal polyposis, 80% or more of the patients have eosinophilic condition in the nasal biopsies there. So it's a eosinophilic driven condition in the vast majority of the cases.
Well, excellent. Well, thank you, Professor Emilio. Thank you to all speakers, Dr. Rizwana and Dr. Adiba. It was really an interesting evening, interesting webinars. We had around 184 participants who really enjoyed all your talks. I'd like to remind you that you will receive an evaluation, hopefully by tomorrow. Please fill in the evaluation and you will get the CME certificate via email. Thank you and have a good night. Take care.
Thank you very much. Salam alaikum to everybody and stay safe. Bye-bye.
Bye. Alaikum salam.
Thank you.
Bye.
Thank you, Doctor.
Take care.
Thank you. Bye-bye.
Bye, Dr. Deep.
Bye-bye.
يعطيكم العافية يعطيكم العافية. Thank you very much.
الله
السلام
يحفظك.
عليكم.
حياكم الله.
بيض الله وجهكم. الله يحفظكم. مع
الله
السلامة.
يسلمك. مشكور بعمر.